Welcome to AETCM, the Emergency Medicine channel. So in today's video, we will be discussing about the control of exsanguinating external hemorrhage. So X is the parameter which has been added to the primary survey as per the new 11th edition of ATLS, that is the Advanced Trauma Life Support. So previously it was A, B, C, D and E. But now an X factor which stands for the exsanguination of external hemorrhage has been added in order to prioritize a major life-threatening condition in trauma, that is the bleeding. So in the chapter statement, they have discussed that the massive external hemorrhage represents an immediate threat to life, and stopping and exsanguinating external bleeding through direct pressure, wound packing or tourniquet application is the first step in primary survey of the trauma patient. Coming to the introduction, so the principle behind introduction of this X parameter prior to the management or prior to the assessment of airway is to make sure that we are ruling out the life-threatening, or we are managing the life-threatening cause of which is a very common life-threatening condition that can result in death due to trauma. So the primary principle is to treat the greatest threat to life first. So rapid trauma primary survey, as we know, is the systematic approach. So in primary survey, we are taking care of the airway, the circulation part, the breathing part. So the primary survey, as we know, is a systematic approach which is done to make sure that we are ruling out or we are assessing and treating the life-threatening conditions of the patient. And massive external hemorrhage is characterized by severe bleeding from the extremity or open wounds that can be the greatest threat to life. So focus on controlling compressible life-threatening external bleeding is what we have to practice in this exsanguination part. So coming to the tourniquet use, so it was recognized as effective. So it was during the World Wars that it was first initiated to be in use or in the practice, and later, like during the early 19th century, they started to use this tourniquet in the war zones, in the military warfares, and later by 20th century or during the early period of 20th century, the tourniquet use was declined, and the reason was the complications that it can happen due to the tourniquet application, that is amputations, rhabdomyolysis and neuropathies. And later in the 1990s and early 21st century, the use of tourniquet was again re-evaluated, and it was made into use after that. So it was adopted widely in the US military initially, which resulted in 85% decrease in deaths due to extremity hemorrhage or injuries. So it was lagged behind military adoption, and events like Sandy Hook tragedy. Sandy Hook tragedy happened in the US. Sandy Hook is actually an elementary school in which a person came and shot the students. Around 26 it was a mass casualty. Around 26 people died, including 20 students and 6 staffs who worked in the elementary school. So one guy who was a 21 years old guy, he came into the school and he used the gun and he shot all these people down. So that was a tragedy that happened. So after that, the massive external bleeding was the cause of death among for all. So after that, a Hartford consensus, a conference was carried out, and it consisted of the trauma surgeons, the emergency physicians, the law enforcement agencies all came together, and they have introduced something called as the threat acronym. So it is to treat, it is like an acronym which was introduced on how to approach the victims of in such case scenarios. So in that, the threat acronym, the T stands for threat suppression, that is the neutralization of active shooter or ongoing threat. H stands for hemorrhage. So in this acronym, after the Hartford consensus conference, they have emphasized emphasized the significance of hemorrhage control, and so after that, this use of tourniquet was again reapplied. The tourniquet was again reassured or re-established in the clinical settings. So hemorrhage control, we have to stop the life-threatening bleeding as early as possible, and R stands for rapid extrication to safety, A for assessment by medical providers, and T, transport to definite care. So, this was the threat acronym which was introduced after the Hartford conference, which followed the Sandy Hook tragedy. Coming to the bleeding control program. So, after that, after the incident in 2014, bleeding control programs were launched. It was to the medical professionals as well as for the public. So, it was transitioned into Stop the Bleed program. So, Tourniquet became standard for trained first responders, bystanders and EMS. So, the benefits which were documented was the lower mortality, reduced transfusion needs, and it comprised of fewer complications. If applied within 2 hours, there was no risk for amputation or major adverse events. Coming to the classification of traumatic hemorrhages. So, traumatic hemorrhages can be compressible hemorrhage as well as non-compressible hemorrhage. So, coming to compressible hemorrhage, it means the bleeding which is visible and controllable without the surgery, controlled by direct pressure, packing and tourniquet application. So, compressible hemorrhage basically indicates the external hemorrhage to which we can apply the pressure, or we can apply a tourniquet or wound packing if it is a deep wound or laceration, and we can stop the bleeding. Whereas non-compressible hemorrhage is characterized as the internal hemorrhage or bleeding inside the body cavities, that is the thorax, abdomen or the pelvis, and it cannot be controlled by the external means. So, in case of exanguination, so one factor is that while we discuss about the exanguination of external hemorrhage, that is the X factor coming before the airway, we are not taking the complete management, or we are not completely managing the circulation part. It is not that we are placing C before A, we are taking control of this compressible hemorrhages. We are taking care of the external, massive external hemorrhages that can be a threat to the life. So, coming to recognition of massive bleeding, you will have, we can see the continuous large volume bleeding, pooling of blood and spurting arterial hemorrhage, which carries the high risk. And coming to pre-hospital and trauma setting, many times external bleeding is already controlled before arrival. So, in the hospital, if exanguination part has been already carried out, we can take care of the airway. We can start with the airway assessment, since from the pre-hospital, if the team has already arrived and taken care of the patient, they might have already done this exanguination part, that is this control of hemorrhage. And if not life threatening, if you are not able to see a life threatening hemorrhage or condition, we can proceed to airway assessment and management. So, first step, coming to the management and immediate action. So, the first step to do is to expose the site completely. So, we have to cut and remove all the clothes, or if there is any tight clothing, we have to loosen it. If there is any jewelries or anything in that site, we have to remove everything. So, the whole bleeding area should be visible, and the primary method that what the protocol suggests is the direct pressure. So, we need to place a sterile gauze exactly over the bleeding point. So, and then we have to apply a firm continuous positive pressure, and we have to avoid repeated lifting to check whether the bleeding has stopped, whether the clot has formed or not, because this can result in a dislodgement. So, again we have to take a sterile gauze, apply direct pressure, apply it and avoid lifting it up very frequently to check whether the clot has been formed, whether the bleeding has stopped or not. So, put a direct compression or keep a direct compression for a specific period of time. Coming to the larger or deeper wounds. So, in case of a larger or deeper wounds, it won't be so much possible to stop the bleeding using just the external pressure or pressure compression technique. So, instead what we can use is the wound packing, that is in that area where there is a deep wound or laceration, we will be taking the sterile gauze pieces and we will be packing or stacking that site with those gauze pieces while maintaining a pressure. So, keep adding gauze until the cavity is filled and the bleeding slows or stops. So, if the bleeding is from the deep sites, if we are packing the gauze pieces, the nearby tissues will have a compression or a pressure from these packed site, and then the bleeding will gradually stop. Coming to site specific notes, so trunk wounds, in case of trunk wounds and scalp lacerations, so we can temporarily control with gauze packing and sustained pressure, continuous resuscitation and the remainder of the primary survey while pressure will be maintained. And if bleeding is not controlled with direct pressure and packing, we can escalate to tourniquet application. So the first step is to take the sterile gauze pieces. If you are seeing a patient who is having an massive external bleeding, the first step to do is to take the gauze pieces and then we have to apply a direct pressure over the site which is injured or where there is severe bleeding. We have to apply direct pressure for a prolonged period of time, and then for in case of a deep wounds or lacerations, what we can do is to do the wound packing. We will be taking a pack of sterile gauzes, we will be stacking it inside the deeper tissues, and if with these two methods, if we are not able to stop the bleeding, we will go for the tourniquet application. And do not perform blind clamp placement into the wounds. That is also a point that they have emphasized. Coming to the tourniquet application. So indication for tourniquet application is if there is a persistent life-threatening extremity bleeding which is not controlled by pressure, packing or a spurting, or in case of a spurting arterial hemorrhage. So placement is, if this is the wound site, we have to place 2 to 3 inches, that is around 5 to 8 centimeters proximal to the bleeding site. So it should be on over the skin and not on the joint and not over the clothing. So initially, as we said, first we have to expose the site and then we will be doing this direct pressure wound packing method. If we couldn't stop bleeding with that, we will go for this tourniquet application. So how to apply? As we mentioned, we have to apply 2 to 3 inches above the wound site, that is around 5 to 8 centimeter proximal to the wound site. If the bleeding continues still after application of the first tourniquet, so now if you have applied the first tourniquet above the injured site, that is 2 to 3 inches above the injured site, if still you couldn't stop the bleeding, if still the bleeding was not stopped, the ATLS new protocol indicates that we can tie one more tourniquet, that is above the first tourniquet which has already been applied. So place, if the bleeding continues, we have to place a second tourniquet 2 to 3 inches proximal to the first. And we need to record the time of application. So usually the tourniquet what we use to control the hemorrhage in the pre-hospital setup will be having a time tag, so we can note down the time, so that because tourniquet, if we are using it for a prolonged period of time, it will have complications like what we discussed before, that is the rhabdomyolysis, neuropathies can occur, it can result in tissue necrosis as well. So we shouldn't go for the prolonged application of tourniquet which will lead to further complications. So what we can do here is we can mark the time and make sure that the tourniquet is not being applied for a longer period of time. So coming to the types of tourniquet which are used, so first one is compact application tourniquet, CAT. So it will have it is black or orange nylon strap with the velcro fastening and a plastic or metal rod for tightening. So it will have a fastening and with a metal rod, and it is most widely used and easy one-handed application, and it specifically has a time tag, as you can see in the image. So there is a metal rod, a strap, and there is a time tag where you can note down the timing at the time in which you have applied this tourniquet for the patient, so that we'll have knowledge about how long this tourniquet has been applied for the patient, and we can prevent or we can take care of the complications that can occur due to that. Next is soft T-white. So this is soft T-white is almost like CAT itself, but the metal rod is much more heavier than what we have seen in the CAT. So it is similar to CAT but with the heavier materials, and it is durable, suitable for harsh environment, and allows rapid reapplication without full removal. So this is what the soft T-white tourniquet looks like. Coming to the next, that is a pneumatic tourniquet. So it's just like the BP apparatus. So it is rare in pre-hospital trauma due to the bulk carrying thing, like we have to carry it. So it is not so available in the pre-hospital setup. So it provides a uniform circumferential pressure, just like we apply the BP apparatus and we inflate or cuff the pressure up. So just like that, it will give a uniform circumferential pressure. So it is most common in surgical or hospital setting than roadside EMS. So if so this is, as we can see in the image, it is just like the BP apparatus. So in the hospital, if we don't have this the other methods, we can, if that is Softy or CAT, we can go for this pneumatic tourniquet application, where you can inflate the cuff, you will be cuffing the pressure and you will be maintaining that, and then the bleeding. With this we will be able to control the hemorrhage of the patient. So this is the image of tourniquet application. As you can see the wound, and above that, so this, the tourniquet what you see here is the C80 with a metal rod. So the injured site, you can see the injured site. So it is 2 to 3 inches above that we have to place the tourniquet. And this is the image of the direct pressure or direct pressure application, what we have to do for in case of a massive external hemorrhage. So just this is a key point or chapter summary. So it says that the X parameter which has been introduced in the ABC prior to the airway management in the primary survey of ATLS algorithm do not waive off the need or do not trivialize the need for the airway management, but it is just that we are controlling the external massive hemorrhage, and it is not that we are putting the circulation part prior to airway. We are not assessing or we are not managing the whole life threatening conditions that can come under the circulation part, but we are taking care of the external massive external hemorrhage that can occur due to a trauma, and after that we will be following the airway management, the breathing part, like how we do. So the X step of X-ABCDE does not diminish the importance of airway assessment and maintenance, nor does it represent a full assessment of circulation. So we are not placing, as I mentioned before, we are not placing the C part, the circulation part, prior to the airway. So X step is a quick evaluation for massive, that is active, large volume and continuous external blood loss. So when present, massive external compressible hemorrhage is immediately controlled upon patient arrival, and bleeding control interventions are life saving, take seconds to initiate and may be provided while other team members simultaneously proceed to initial basic airway management. So once again, X stands for exsanguinating external hemorrhage. So we are trying to stop the massive external hemorrhage, and we are doing the bleeding control prior to the airway management, and thereby we can stop one of the major cause that is resulting in death due to trauma. So that's it. Thank you for watching.